The year is 2023. You wake up on a friend's couch in Phoenix, Arizona. Not to an alarm, but to the gnawing ache spreading through your body like ice water in your veins. Your muscles cramp, your skin crawls. Nausea rolls through your stomach in waves. You haven't used in 8 hours, and your body is screaming for relief. Not heroin anymore. That stopped working months ago. Not pills. Those are too expensive, too hard to find. You need fentanyl, a substance so potent that 2 milligrams, an amount smaller than a few grains of salt, can stop your heart. You check your phone, 3 missed calls from your mother, a text from your sister, please call me, or worried. You don't respond. Instead, you scroll to a different name, send a different message. Within 20 minutes, you're meeting someone in a Circle K parking lot, handing over $40 for a single blue pill stamped M30. It looks exactly like the oxycodone you used to get prescribed, but it's not. It's fentanyl, pressed in someone's garage with no quality control, no dosage consistency, no regard for your life. You take half the pill in the parking lot. You tell yourself half is safer. You tell yourself you're being careful. Within minutes, the sickness fades, replaced by warmth, by relief, by the chemical embrace that makes everything else disappear. You close your eyes and breathe. Across America, 150 people will die today from fentanyl. Tomorrow, another 150. The day after that, the same. 7 people every hour, 1 person every 8 minutes. This is the fentanyl crisis. And unless you understand how we got here, how a surgical anesthetic invented in a Belgian laboratory became the deadliest drug in American history, you wouldn't survive it. Before we dive into the complete history of fentanyl, take a moment to like this video and subscribe to the channel. If you're here for sleep, you're in exactly the right place. This is a long, detailed journey through the creation, evolution, and catastrophic spread of the most lethal synthetic opioid ever mass-produced, a substance that has killed more Americans than car accidents, gun violence, and most diseases combined. We're going to explore everything: how fentanyl was invented in 1959 by a Belgian chemist trying to improve surgical anesthesia, how it became a legitimate medical tool used in operating rooms worldwide, how it was weaponized by Russian special forces, how Mexican cartels learned to synthesize it in clandestine labs using precursor chemicals from China, how it infiltrated the American drug supply and transformed the opioid epidemic into a mass casualty event. This isn't just statistics and policy discussions. We're going to walk through what it feels like, what it looks like, who it kills, and why it's nearly impossible to stop. We'll move slowly, thoroughly, with all the dark details and human stories that reveal how America arrived at this point. So settle in, get comfortable, and let's trace the complete history of fentanyl, from a laboratory breakthrough to a street-level catastrophe. To understand fentanyl's role in the current crisis, you need to understand where it came from. Fentanyl wasn't created by drug cartels or street chemists. It was invented by a legitimate pharmaceutical researcher working for a respected Belgian company, trying to solve a real medical problem. The year is 1959. Dr. Paul Janssen, a Belgian chemist and founder of Janssen Pharmaceutical, is working on developing new analgesics, pain-relieving drugs, for use in surgery. At the time, morphine is the standard surgical anesthesia, but it has significant drawbacks. It causes respiratory depression, nausea, and has a relatively slow onset. Surgeons need something faster acting, more potent, and more controllable. Janssen synthesizes a compound he calls fentanyl, technically N-phenyl N into 1-penethyl-2 into 4-piperidonyl proponamide. It's a synthetic opioid, meaning it mimics the effects of natural opiates like morphine, but is created entirely in a laboratory. The key difference: fentanyl is approximately 100 times more potent than morphine. A single milligram of fentanyl produces the same analgesic effect as 100 milligrams of morphine. This potency is both fentanyl's greatest medical advantage and its most dangerous characteristic. In controlled medical settings, it means doctors can use tiny doses to achieve profound pain relief with rapid onset, perfect for surgery. In uncontrolled settings, it means even microscopic dosing errors can be fatal. Throughout the 1960s and 1970s, fentanyl is adopted by hospitals worldwide. It's used primarily in 2 forms: as an intravenous anesthetic during surgery and as a component of epidural anesthesia for pain management during childbirth. Anesthesiologists appreciate its reliability. It works within minutes, wears off relatively quickly, and when administered by trained professionals with precise equipment, it's remarkably safe. In 1990, the pharmaceutical company Janssen develops a fentanyl transdermal patch, a slow-release system that delivers fentanyl through the skin over 72 hours. The analgesic patch, as it's branded, is approved for chronic pain management in cancer patients. It's meant for people with severe, persistent pain who have already developed opioid tolerance. The packaging includes bold warnings, not for opioid-naive patients, for chronic pain only, potentially fatal. The medical community understands fentanyl's risks. In hospitals, it's stored in locked cabinets. Doses are measured in micrograms, millions of a gram. Patients receiving fentanyl are monitored continuously for respiratory depression. Naloxone, the opioid overdose reversal agent, is kept immediately available. Fentanyl in medical settings is managed with extreme caution because everyone involved understands its lethal potential. But outside medical settings, that caution doesn't exist. The first documented cases of illicitly manufactured fentanyl appear in the United States in the late 1970s. In 1979, investigators in Orange County, California, respond to a cluster of overdose deaths among heroin users. Toxicology reports reveal the presence of fentanyl, but not pharmaceutical fentanyl. This is a slightly altered analog called alpha-methylfentanyl, synthesized in a clandestine laboratory. Someone somewhere has read the scientific literature on fentanyl synthesis and figured out how to make it illegally. The implications are staggering. Unlike heroin, which requires opium poppies, agricultural products that must be grown, harvested, and smuggled, fentanyl can be synthesized entirely from industrial chemicals in a laboratory. No fields, no weather dependence, no agricultural limitations, just chemistry. Throughout the 1980s, sporadic outbreaks of illicitly manufactured fentanyl analogs appear across the United States, primarily in California. Street names emerge: China White, synthetic heroin, designer drugs. The Drug Enforcement Agency identifies over a dozen fentanyl analogs circulating on the black market, each with slightly different molecular structures designed to evade drug scheduling laws, technically legal until authorities specifically ban each variant. These early fentanyl analogs cause waves of deaths. In 1988, one batch in Pennsylvania kills 16 people in 3 weeks. In 1991, fentanyl analogs kill over 100 people in New York. Each outbreak follows the same pattern. A new variant appears, users accustomed to heroin take their usual dose, and people start dying. The potency differential is too extreme. What seems like a normal amount of powder contains a lethal overdose. But these outbreaks are localized and relatively short-lived. Law enforcement identifies the clandestine lobs, makes arrests, and the supply disappears. Fentanyl remains primarily a medical drug, occasionally diverted for illicit use, but not yet a dominant force in illegal drug markets. That changes in the 2000s, driven by two factors: the prescription opioid epidemic creating a massive population of opioid-dependent Americans, and the rise of Chinese pharmaceutical manufacturing. As discussed in the pill mill era, millions of Americans became addicted to prescription opioids like OxyContin during the 2000s. When prescriptions became harder to obtain due to reformulations, regulations, and crackdowns, many people transitioned to heroin. By 2010, heroin use in America had increased dramatically, particularly among white, middle-class users who had started with legal prescriptions. This created enormous demand for opioids on the black market. Mexican drug trafficking organizations, which had traditionally focused on cocaine and marijuana, recognized the opportunity and ramped up heroin production. Poppy cultivation in Mexico increased sharply. Heroin purity improved. Prices dropped. But even with increased production, Mexican traffickers face limitations. Growing poppies takes time, land, water, and labor. Transporting heroin across the border carries risks of interdiction. Fentanyl offered a solution to all those problems, and the knowledge of how to make it was about to become globally accessible. In the mid-2000s, Chinese chemical manufacturing began producing fentanyl and fentanyl precursors, the chemicals needed to synthesize fentanyl, on an industrial scale. China had become the world's leading producer of pharmaceutical ingredients, operating thousands of chemical factories with minimal regulatory oversight. Some of these companies began advertising fentanyl and fentanyl analogs openly on the internet, selling to anyone with a credit card and a shipping address. This was technically legal under Chinese law at the time. Fentanyl wasn't controlled in China until 2015, and many fentanyl analogs remained uncontrolled even longer. Chinese suppliers could legally manufacture and export substances that were killing thousands of Americans because
those substances weren't illegal in China. Mexican cartels noticed. Instead of growing poppies, refining opium, and smuggling bulky heroin shipments, they could order fentanyl precursors from China, synthesize fentanyl in Mexican labs, and smuggle far smaller quantities of far more potent product into the United States. The economics were irresistible. 1 kilogram of fentanyl, small enough to fit in a backpack, could be cut and pressed into hundreds of thousands of counterfeit pills or mixed into heroin to stretch the supply exponentially. By 2013, fentanyl was appearing regularly in the American drug supply. By 2015, it was common. By 2017, it was everywhere, and people were dying in unprecedented numbers. Let's talk about why fentanyl is so uniquely dangerous. This isn't just another drug. The pharmacological properties of fentanyl make it exceptionally lethal in ways that even heroin and prescription opioids are not. Fentanyl is a synthetic opioid that binds to mu-opioid receptors in the brain, spinal cord, and gastrointestinal system. These receptors are part of the body's natural pain regulation system. When activated by opioids, they produce analgesia, pain relief, and euphoria. They also suppress respiration. This is true of all opioids: morphine, heroin, oxycodone, fentanyl. They all slow your breathing. At high enough doses, they stop it entirely. The critical difference is dose. A lethal dose of morphine is approximately 200 milligrams for an opioid-naive person. A lethal dose of heroin is around 30 milligrams. A lethal dose of fentanyl is 2 milligrams. 2 milligrams. That's about the weight of a few grains of salt, a few granules of sand, a snowflake. You cannot eyeball that amount accurately. You cannot be careful with doses that small without laboratory equipment. And on the street, fentanyl isn't distributed with laboratory equipment. It's mixed in blenders, stirred in plastic buckets, pressed in pill presses ordered from China, packaged in basements and garages by people with no training in pharmacology or chemistry. This creates catastrophic inconsistency. Imagine a batch of counterfeit oxycodone pills, each supposedly containing 30 milligrams of oxycodone. In reality, they contain fentanyl. The person mixing the batch dumps fentanyl powder and filler powder into a blender, runs it for a few minutes, and presses pills. But the mixing is never perfect. One pill might contain 0.5 milligrams of fentanyl, a dose that will get you high but probably won't kill you. The next pill from the same batch might contain 3 milligrams, more than enough to stop your breathing. You can't tell by looking. The pills are identical in appearance. Same stamp, same color, same size. But one is survivable and the next is lethal, and there's no way to know which you're taking until it's in your body. This is called hotspotting, uneven distribution of active ingredient in a mixed product. It's a known problem in pharmaceutical manufacturing, which is why legitimate drug companies use industrial-scale mixing equipment, rigorous quality control, and batch testing. Clandestine drug manufacturers have none of that. They have blenders and good intentions at best, deliberate negligence at worst. Fentanyl also acts faster than other opioids. When injected, fentanyl crosses the blood-brain barrier almost immediately, producing effects within seconds. Snorted, it works within minutes. This rapid onset means users have almost no time to recognize an overdose and seek help. With heroin, there's often a window, 5, 10, sometimes 15 minutes between injection and full respiration depression. People lose consciousness gradually. Bystanders notice something is wrong. There's time to call 911, to administer naloxone, to intervene. With fentanyl, people go from fine to unresponsive in under a minute. They inject, sit down, and stop breathing before they realize anything is wrong. Friends find them blue and cold. Paramedics arrive to bodies, not patients. The speed of fentanyl turns overdose from a medical emergency into a mortality statistic. There's also the issue of fentanyl analogs. Remember, fentanyl is just one molecule in a family of related compounds. By making small modifications to the fentanyl molecule, adding a fluorine atom here, changing a carbon chain there, chemists can create hundreds of fentanyl analogs, each with slightly different properties. Some are less potent than fentanyl, some are equally potent, some are more potent. Carfentanil, for example, is a fentanyl analog developed for sedating large animals, elephants, rhinoceroses, moose. It is approximately 100 times more potent than fentanyl, which means it's roughly 10,000 times more potent than morphine. A lethal dose for a human is measured in micrograms, millions of a gram, amounts so small they're invisible to the naked eye. Carfentanil appeared in the American drug supply in 2016. In Ohio alone, it caused over 400 deaths between July and December.
That year, people who thought they were buying heroin were actually getting carfentanil-laced product. They took their usual dose and died instantly. First responders arriving at overdose scenes had to wear hazmat gear because simply touching the powder could cause overdose through skin absorption. Law enforcement agencies issued warnings. Assume all white powder is potentially contaminated with fentanyl or fentanyl analogs. Don't touch it without gloves. Don't breathe near it. Treat every scene as hazardous material response. The drug supply had become so toxic that even investigating it posed lethal risks. And then there's the issue of tolerance inconsistency. Regular opioid users develop tolerance. Their bodies adopt to the drug, requiring higher doses to achieve the same effect. Someone who uses heroin daily can survive doses that would kill an opioid-naive person. But tolerance to different opioids isn't perfectly cross-tolerant. Someone with high heroin tolerance has some protection against fentanyl, but not complete protection. The potency jump is too extreme. People who could safely inject a half gram of heroin might still overdose on a few milligrams of fentanyl. This creates a situation where even experienced drug users, people who have been using opioids for years, who know their bodies and their limits, die unexpectedly. They're not being reckless. They're not intentionally overdosing. They're using what they think is their normal supply, and it's contaminated with fentanyl in concentrations high enough to kill them. The pharmacology also makes fentanyl overdoses harder to reverse. Naloxone, sold under the brand name Narcan, is an opioid receptor antagonist. It blocks opioid receptors, reversing overdose and restoring breathing. For heroin or prescription opioid overdoses, 1 or 2 doses of naloxone are usually sufficient. For fentanyl overdoses, especially with analogs like carfentanil, multiple doses are often required. 4, 6, 8 doses of naloxone might be needed to revive someone. And even then, fentanyl's effects can outlast naloxone, causing people to slip back into overdose after initial revival. First responders describe arriving at scenes where they've administered 6 doses of naloxone, far more than standard protocols, and the patient is still unresponsive. By the time they get the person breathing again, they've used entire kits meant to last a week, and tomorrow there will be more overdoses. This is the chemistry of death. Fentanyl isn't just dangerous because it's a drug. It's dangerous because its potency, its rapid onset, its analog variability, and its resistance to reversal combine to create nearly perfect lethality. In uncontrolled settings with inconsistent mixing and uninformed users, it kills reliably and efficiently. And it's everywhere. Understanding how fentanyl reaches American drug users requires understanding the global supply chain that produces and distributes it. This isn't a simple story of cartels growing drugs and smuggling them across borders. It's a complex, multinational operation involving Chinese chemical manufacturers, Mexican trafficking organizations, international shipping companies, and digital communication platforms. Let's start in China, specifically in industrial regions like Hebei, Guangdong, and Jiangsu provinces, where thousands of chemical manufacturing facilities operate. These aren't illegal operations hidden in jungles. They're registered businesses, often operating legally under Chinese law, producing pharmaceutical precursors and chemical compounds for export worldwide. In the 2010s, some of these companies began advertising fentanyl and fentanyl analogs directly on the internet. They created English-language websites with product catalogs listing dozens of synthetic opioids, complete with pricing, purity guarantees, and shipping options. They accepted payment via wire transfer or cryptocurrency. They shipped internationally via postal services and private carriers like FedEx and DHL. A person in the United States, whether an individual drug user or a representative of a trafficking organization, could simply email a Chinese supplier, place an order for kilogram quantities of fentanyl or fentanyl precursors, pay via Bitcoin, and receive a package directly from China within 2 weeks. The package would be labeled as industrial chemical or research compound, technically true but deliberately misleading. Customs inspectors, overwhelmed by millions of international packages daily, would miss the vast majority of shipments. This direct-to-consumer fentanyl distribution caused the first wave of fentanyl deaths in North America. Between 2013 and 2017, most fentanyl in the United States came directly from China. Individuals and small-scale drug dealers were ordering it themselves, often with fatal results. People with no understanding of fentanyl's potency would order a kilogram, thinking it was like buying a kilogram of cocaine, then
attempt to use or distribute it with no concept of appropriate dosing. Clusters of overdose deaths would appear in communities where someone had received a Chinese shipment. The Chinese government initially did little to stop this. Fentanyl and many fentanyl analogs weren't controlled substances under Chinese law until 2015. Even after fentanyl itself was scheduled, manufacturers simply switched to uncontrolled analogs, making tiny molecular modifications that kept the products technically legal while maintaining their opioid effects. This was the same designer drug strategy that had appeared in the 1980s, but now operating on an industrial international scale. International pressure eventually forced China to act. In 2019, after years of diplomatic negotiations and pressure from the United States, China classified all fentanyl analogs as controlled substances, making them illegal to produce or export. Chinese authorities shut down numerous chemical manufacturers and arrested several executives. This didn't stop fentanyl production, it redirected it. Mexican drug trafficking organizations had been watching the Chinese supply chain closely. They recognized that fentanyl offered enormous advantages over heroin: smaller shipment sizes, higher profit margins, no agricultural requirements. But they didn't want to rely on direct Chinese imports, which were becoming more difficult and carried risks of interdiction. Instead, they built their own fentanyl production infrastructure. They purchased precursor chemicals from China, not finished fentanyl, but the chemical building blocks needed to synthesize it. These precursors were less tightly controlled and easier to ship. Mexican cartels then hired chemists, established clandestine laboratories, and began manufacturing fentanyl themselves. The Sinaloa cartel and the Jalisco New Generation cartel, CJNG, became the primary producers of fentanyl destined for the United States. They established networks of labs in Sinaloa, Jalisco, and Durango states. These weren't crude operations. Some were sophisticated facilities with trained chemists, quality control processes, and high production capacity. Others were makeshift labs in rural warehouses, garages, or houses, churning out product with minimal safety precautions. The precursor chemicals still came from China, but now they were shipped to Mexico, often through third countries to obscure their origin. A chemical shipment might go from China to Guatemala, then trucked into Mexico, or shipped to a Mexican port with false labeling. Chinese suppliers adapted their operations, becoming less visible but no less active. Once synthesized in Mexico, fentanyl is smuggled into the United States primarily through official ports of entry, not remote border crossings, but legal checkpoints where millions of vehicles cross daily. Fentanyl's extreme potency makes this practical. A few kilograms of fentanyl, which can fit in a car's hidden compartment, represents millions of doses and millions of dollars in street value. Compare this to marijuana or cocaine, where profitable smuggling requires moving hundreds of kilograms. Fentanyl is hidden in vehicle compartments, mixed into legitimate cargo, swallowed in pellets by human couriers, or simply placed in luggage and driven through inspection points where only a tiny fraction of vehicles are searched. The volume of cross-border traffic, hundreds of thousands of vehicles per day, makes comprehensive inspection impossible. Even with drug-sniffing dogs, X-ray technology, and random searches, the vast majority of smuggling attempts succeed. Once inside the United States, fentanyl enters distribution networks that were originally built for heroin and cocaine. Mexican cartels partner with American distributors, sometimes gang organizations, sometimes independent dealers, who move the product from border regions to cities across the country. Fentanyl travels from San Diego to Los Angeles, from El Paso to Dallas, from Nogales to Phoenix, then onward to every corner of America. At the street level, fentanyl is either sold as itself, as fentanyl powder for users who know what they're getting, or adulterated into other drugs. This is where it becomes most lethal. Drug dealers mix fentanyl into heroin to increase potency and stretch supply. They press it into counterfeit pills designed to look like Xanax, Percocet, or oxycodone. They even mix it into cocaine and methamphetamine, either intentionally or through cross-contamination in processing. The result is a contaminated drug supply where nearly anything purchased on the street may contain fentanyl, often without the buyer's knowledge. People who have never used opioids, who are buying what they think is cocaine or Xanax, die from fentanyl overdoses. The substance has spread beyond the opioid-using population into the broader drug-using community. There's also a dark economic logic to fentanyl adulteration. Fentanyl is cheap to produce, heroin is
expensive. It requires poppies, labor, time. By cutting heroin with fentanyl, dealers increase their profit margins dramatically. A kilogram of pure heroin might cost $50,000 wholesale. That same kilogram cut with fentanyl and fillers can be stretched into 2 or 3 kilograms of heroin that's actually mostly filler with enough fentanyl to create opioid effects. The economic incentive is overwhelming. Some dealers rationalize this by arguing that users want stronger product, that fentanyl's potency is a selling point. There's some truth to this. Addiction is characterized by tolerance, and users with high tolerance actively seek strong opioids. But there's a difference between knowingly selling fentanyl and secretly adulterating heroin with it. The latter is essentially poisoning your customers, and many dealers either don't care or don't understand the risks. Attempts to disrupt the supply chain have had limited success. Law enforcement agencies have seized large quantities of fentanyl at the border, tons of powder, millions of pills. The DEA has arrested cartel members, distributors, and dealers. The State Department has pressured China and Mexico to increase enforcement. But the supply continues. When one lab is shut down, another opens. When one trafficking route is interdicted, another is established.
The fundamental problem is that fentanyl production is decentralized, small-scale, and highly profitable. Unlike cocaine, which requires large coca plantations that can be identified and destroyed, or heroin, which requires extensive opium poppy cultivation, fentanyl can be made in a single room with equipment worth a few $1,000s. The knowledge is available online. The precursors are commercially available. The demand is insatiable. Stopping it requires solving the demand side, the millions of Americans addicted to opioids, not just the supply side. And so the fentanyl keeps flowing, from Chinese chemical plants to Mexican labs to American streets, a supply chain of death operating efficiently and relentlessly, feeding an epidemic that shows no signs of slowing. Numbers become abstract. 150 deaths per day is a statistic. Over 70,000 fentanyl deaths per year is a headline. To understand what this crisis actually means, you need to hear individual stories, real people who died from fentanyl and the families they left behind. Meet Alexis. She was 19 years old in 2018, a college student in Pennsylvania studying psychology. She had struggled with anxiety throughout high school, saw a therapist regularly, and was prescribed Xanax for panic attacks. She took it as prescribed for a year. When her prescription ended and her doctor suggested transitioning to non-pharmaceutical anxiety management, she struggled. The anxiety came roaring back. She knew someone at college who sold Xanax, just leftover pills from his own prescription, he said. She bought 10 pills for $20. They looked exactly like her old prescription, white bars stamped with Xanax. She took one before a difficult exam. It helped. She took another the next week, then another. The fourth pill killed her. It wasn't Xanax. It was a counterfeit pressed with fentanyl. She took it in her dorm room at 9 p.m. on a Tuesday. Her roommate found her at 11 p.m., blue and cold, foam around her mouth. Paramedics tried to revive her. 6 doses of naloxone didn't work. She was declared dead at the hospital at 11:47 p.m. Alexis had never used heroin, had never sought out opioids. She thought she was taking an anti-anxiety medication to manage legitimate symptoms. The pill that killed her was visually indistinguishable from pharmaceutical Xanax. Toxicology later showed it contained approximately 2.5 milligrams of fentanyl, enough to kill someone with no opioid tolerance. Her parents, David and Sandra, became activists. They testified before Congress. They spoke at high schools. They shared Alexis's story with anyone who would listen, warning that counterfeit pills are everywhere and indistinguishable from real ones. But they can't bring her back. She was 19. She wanted to be a therapist. She died from a pill she thought was safe. Or consider Marcus, a 42-year-old construction worker in Ohio. He'd been using heroin since 2011, when his prescription pain medication for a back injury ran out, and he couldn't afford pain management. He'd been through rehab twice, relapsed both times. He wasn't proud of his addiction, but he'd learned to manage it. He used just enough to avoid withdrawal, held down work, paid his child support. His ex-wife knew about his addiction but maintained a relationship because he was good with their kids, showed up to every birthday and soccer game. In March 2020, Marcus bought what he thought was heroin from his regular dealer. He'd been buying from the same person for 3 years, trusted the product. He used alone in his apartment. First mistake, but common. Harm reduction advocates emphasize,
Never using alone, but most addicts do because of stigma, shame, or simply circumstance. He injected his usual dose. Within 30 seconds, he knew something was wrong. The rush was too intense, too fast. He tried to stand, to reach his phone, to call for help. He collapsed. His neighbor heard the thud and called 911 20 minutes later, concerned but not urgent. By the time paramedics arrived, Marcus had been without oxygen for over 15 minutes. They revived him, but his brain had been damaged. He survived, but with severe cognitive impairment, unable to work, care for himself, or maintain the relationships he'd fought so hard to preserve. The heroin had been cut with fentanyl. His dealer didn't know. His supplier had started adulterating the product without informing anyone down the chain. Marcus's dealer had sold the same batch to 8 other people that week. 2 died. 3 overdosed but survived. 3 got lucky and happened to get portions of the batch with lower fentanyl concentrations. Marcus is 46 now. He lives in a supervised care facility. His children, now teenagers, rarely visit. The person he was, flawed but functional, addicted but loving, is effectively gone, replaced by someone diminished and dependent. His family says sometimes they wish he had died instead of surviving like this. They feel guilty for thinking it, but they can't help it. There's also Riley, a 16-year-old in Arizona who took what he thought was Percocet at a party in 2021. He'd never used opioids before.
A friend offered him a pill, said it would help him relax and feel good. He took half. He died on the bathroom floor while the party continued in the next room. No one realized anything was wrong until someone needed the bathroom and found his body. He'd been dead for over an hour. Riley was a sophomore in high school. He played basketball. He had a girlfriend. He'd been accepted to his summer science program. His parents, both physicians, had talked to him about drugs, thought he understood the risks. They didn't know counterfeit pills looked exactly like real ones, that teenagers were buying them on Snapchat, that fentanyl had so thoroughly infiltrated the drug supply that even a single experimental pill could be lethal. His mother, Dr. Jessica Martinez, now runs a nonprofit distributing fentanyl test strips and naloxone to schools. She speaks about Riley openly, showing his picture, describing the kind of kid he was. Not troubled, not an addict, just a teenager who made one mistake and paid with his life. She emphasizes that this could happen to any kid, any family. There's no profile, no warning signs, just the catastrophic bad luck of getting a contaminated pill. Then there's the story of Emma and Jake, a couple in their late 20s in Seattle, both in recovery from heroin addiction. They'd been clean for 18 months, attending NA meetings, working, rebuilding their lives. They relapsed together on a Friday night. The stress of financial problems, of fighting, of the endless grind of staying sober finally broke them. They bought heroin from someone they didn't know. Their old dealer had been arrested months earlier. They used together in their apartment, a harm reduction practice that likely saved Jake's life. Emma overdosed first. Jake administered naloxone, called 911, performed CPR. Paramedics arrived and took over, administering additional naloxone. Emma survived, but the overdose triggered a cascade of events: hospitalization, loss of employment, eviction, breakdown of their relationship. Jake, racked with guilt, used again 2 weeks later. He wasn't as lucky. No one was there to revive him. He died alone in a motel room, a naloxone kit in his backpack unused because unconscious people can't self-administer. Emma is alive but shattered. She carries the guilt of the relapse that set everything in motion, the loss of Jake, the knowledge that they almost made it. She's clean again now, working at a needle exchange, trying to prevent other people's deaths. But the grief is omnipresent, suffocating. She says every day is a choice between continuing to exist with the pain or ending it. So far, she's chosen to exist, but it's hard. These stories, Alexis, Marcus, Riley, Emma, and Jake, are not exceptional. They're representative. Multiply them by hundreds of thousands, and you begin to grasp the human scale of the fentanyl crisis. Every statistic is a person. Every death is a family destroyed, a future erased, a network of relationships shattered. The trauma extends beyond the people who die. Parents lose children and never recover. Siblings lose brothers and sisters and carry survivor's guilt. Children lose parents and grow up with abandonment trauma. Friends find bodies and live with the images forever. First responders develop PTSD from working overdose after overdose, trying to save people who are already brain dead. Entire communities are traumatized. Small towns in New England, the Rust Belt.
Appalachia, the Southwest, places already struggling with economic decline, are now also dealing with epidemic-level overdose deaths. Schools have naloxone kits in every classroom. Librarians are trained to reverse overdoses. Coroners are overwhelmed. Funeral homes are fully booked. And unlike previous drug crises that disproportionately affected specific communities, fentanyl kills indiscriminately. It kills the homeless and the housed, the employed and unemployed, teenagers and middle-aged adults, people with long addiction histories, and people experimenting for the first time. It kills in cities and rural areas, in blue states and red states, in wealthy communities and poor ones. No one is safe. That's the message harm reduction advocates try to communicate. If you use drugs, any drugs, not just opioids, assume they're contaminated with fentanyl. Use fentanyl test strips. Never use alone. Have naloxone available. Start with tiny doses. These precautions save lives, but they're not foolproof, and many people don't follow them because they don't believe they're at risk until it's too late. The human toll of fentanyl is a grief that saturates American society, a mass casualty event unfolding in slow motion, one overdose at a time, one family at a time, in every state, every week, with no end in sight. The fentanyl crisis didn't happen in a vacuum. It happened because institutions, government agencies, healthcare systems, law enforcement, pharmaceutical companies failed to prevent it, failed to respond adequately, and in some cases actively contributed to the conditions that allowed it to flourish. Let's start with the Drug Enforcement Agency. The DEA is the federal agency responsible for enforcing controlled substance laws and preventing drug trafficking. In theory, they should have been the first line of defense against fentanyl. In practice, they were overwhelmed, underfunded, and structurally unable to respond effectively. The
The DEA's traditional approach to drug enforcement focuses on large-scale trafficking organizations, interdiction at borders and ports, and prosecution of high-level distributors. This model worked reasonably well for cocaine and heroin, which required large shipments, extensive distribution networks, and significant infrastructure. But fentanyl doesn't fit that model. Because fentanyl is so potent, significant quantities can be smuggled in small packages. There's no need for ton-sized shipments or elaborate smuggling operations. A few kilograms, easily concealed, represents millions of doses. Traditional interdiction strategies designed to catch large drug shipments missed the vast majority of fentanyl entering the country. The DEA also struggled with the analog problem. Every time they scheduled a fentanyl analog as a controlled substance, Chinese manufacturers would create a new analog with a slightly different molecular structure, rendering it technically legal again. This cat-and-mouse game continued for years until China's blanket scheduling of all fentanyl analogs in 2019. Even then, enforcement was inconsistent, and precursor chemicals remained relatively accessible. Domestically, the DEA's focus on arresting street-level dealers did little to stem the fentanyl supply. Dealers are easily replaced. Arresting one person just creates a vacuum filled by another. Without addressing the demand side, the millions of addicted Americans who need opioids, supply-side enforcement is essentially futile. The FDA, Food and Drug Administration, also bears responsibility. For decades, the FDA approved and allowed the marketing of highly addictive opioid medications, often based on pharmaceutical company research that downplayed addiction risks. The agency failed to require adequate post-market surveillance to identify problems early, and when the opioid epidemic became undeniable, the FDA's response was slow and inadequate. It wasn't until 2019 that the FDA began requiring training for physicians who prescribe opioids. By then, millions of Americans were already addicted, many of whom had transitioned to illicit opioids, including fentanyl. The regulatory response was more than a decade too late. The Centers for Disease Control and Prevention issued prescribing guidelines in 2016, recommending lower doses and shorter durations for opioid prescriptions. These guidelines were important, but they had unintended consequences. Many doctors, fearing legal repercussions or simply wanting to avoid the hassle of prescribing opioids, abruptly cut off patients who had been on stable opioid regimens for years. These patients, now in withdrawal and desperate, turned to the street supply, where they encountered fentanyl. The CDC guidelines were well-intentioned, but implemented without adequate support systems. There was no surge in addiction treatment funding, no expansion of pain management alternatives, no safety net for patients being tapered off opioids. People were simply cut off and left to fend for
themselves, many of whom ended up addicted to fentanyl. Healthcare systems failed in multiple ways. Insurance companies made addiction treatment difficult to access, requiring prior authorizations, limiting coverage, refusing to pay for long-term residential treatment. Medication-assisted treatment, using buprenorphine or methadone to manage opioid addiction, remained heavily restricted by regulations, requiring special licenses, limiting the number of patients doctors could treat, and creating barriers that kept treatment inaccessible to most people who needed it. Emergency departments treated overdoses, but rarely connected patients to ongoing addiction care. Someone would be revived with naloxone, observed for a few hours, and discharged with no follow-up, no referral, no intervention. Within days or weeks, they'd overdose again. Hospitals weren't equipped or incentivized to provide addiction treatment, so they didn't. Mental health and addiction treatment infrastructure was and remains catastrophically underfunded. Most communities have waiting lists weeks or months long for addiction treatment. Residential treatment beds are scarce and expensive. Outpatient programs are overwhelmed. Psychiatric care, which often co-occurs with addiction, is nearly impossible to access for people without excellent insurance. The result is that people who want help often can't get it. They call treatment centers and are told there are no openings. They try to get appointments with addiction specialists and are told the next availability is 3 months away. They can't afford residential treatment, which can cost tens of thousands of dollars, so they keep using and they keep dying. Law enforcement's response has been inconsistent and often counterproductive. Some jurisdictions adopted harm reduction approaches, distributing naloxone, supporting needle exchanges, and diverting people to treatment instead of jail. Others doubled down on criminalization, arresting users, prosecuting dealers for murder when their customers overdosed, and treating addiction as a moral failing rather than a medical condition. Prosecuting dealers for overdose deaths became increasingly common in the fentanyl era. If someone sold drugs that caused a death, they could be charged with manslaughter or even murder. Prosecutors argued this held dealers accountable and deterred dangerous sales. But in practice, it often punished low-level users who sold small amounts to support their own addiction, while having little impact on major trafficking organizations. And it created a chilling effect where drug users became afraid to call 911 during overdoses, fearing lethal consequences for themselves or their friends. Good Samaritan laws, which provide immunity from prosecution for people who call 911 during an overdose, exist in many states, but are inconsistently applied and poorly understood. Many people don't know they exist or don't trust them or have outstanding warrants that make calling law enforcement risky regardless of immunity. So overdoses happen alone, without intervention, and people die preventably. Pharmaceutical companies, having created the prescription opioid epidemic that led to widespread opioid addiction, faced minimal accountability. Purdue Pharma declared bankruptcy, the Sackler family gave up some of their wealth but maintained billions, and other opioid manufacturers settled lawsuits for amounts that were tiny compared to their profits. No executives went to prison. The companies paid fines, issued apologies, and continued operating. The settlements did provide funding for addiction treatment and prevention, billions of dollars distributed to states and localities. But even these funds are being misallocated. Some states are using opioid settlement money to plug budget holes rather than funding treatment. Others are spending it on law enforcement and prisons instead of healthcare. The opportunity to build comprehensive addiction treatment infrastructure with settlement money is being partially squandered. International cooperation has been weak. China eventually scheduled fentanyl analogs, but enforcement is inconsistent, and precursor chemicals remain available. Mexico is overwhelmed by cartel violence and corruption, with limited capacity to shut down fentanyl labs even when locations are known. The US government has limited leverage. Economic sanctions and diplomatic pressure have achieved some results, but nothing close to what's needed. Border security measures have increased, more inspections, better technology, more agents, but the fundamental problem remains. Fentanyl is too small, too potent, and too profitable to stop at the border. Even if interdiction rates doubled, the vast majority of fentanyl would still get through because the volume of legitimate cross-border traffic is simply too large to inspect comprehensively. The structural problem is that the fentanyl crisis requires a public health response, but the United States has
primarily deployed a law enforcement response. Arresting people doesn't cure addiction. Seizing drugs doesn't eliminate demand. Building walls doesn't address the underlying pain, physical, emotional, economic, that drives people to use opioids in the first place. Effective responses to addiction require massive investment in treatment, housing, employment, mental health care, and community support systems. These are expensive, long-term commitments that don't produce immediate, visible results. Law enforcement responses, arrests, seizures, prosecutions, are cheaper, faster, and politically popular. So that's what we do, even though it doesn't work. Until the institutional response shifts from punishment to treatment, from interdiction to harm reduction, from criminalization to healthcare, the fentanyl crisis will continue unabated. The tools to address it exist, the knowledge exists. What's missing is political will and sustained funding. And while institutions debate and delay, 150 people die every day. In the absence of adequate institutional response, grassroots harm reduction movements have emerged as the front line of defense against fentanyl deaths. These are community organizations, often run by current or former drug users, providing services that save lives even when government systems fail. Harm reduction is a philosophy that accepts drug use as a reality and works to minimize its harms rather than demanding abstinence. It's pragmatic rather than idealistic. It recognizes that telling people to just stop using doesn't work, and that people who use drugs deserve dignity, compassion, and support, regardless of whether they're ready to quit. The core interventions of harm reduction in the fentanyl era are straightforward. Distribute naloxone, provide fentanyl test strips, operate supervised consumption sites, and maintain needle exchange programs. Naloxone distribution has become widespread. Organizations distribute free naloxone kits, nasal sprays, or auto-injectors to anyone who might witness an overdose. Drug users, family members, friends, homeless service providers, librarians, teachers. Training is simple. If someone is unresponsive and not breathing, administer naloxone and call 911. The medication has no effect on people who aren't experiencing opioid overdose, so there's no risk in using it if you're unsure. Between 1996 and 2021, harm reduction organizations and bystanders reversed over 50,000 opioid overdoses using naloxone. That's 50,000 people who would be dead but are alive because someone had naloxone and knew how to use it. Many of those people went on to get treatment, to achieve recovery, to rebuild their lives. Others kept using but survived another day, maintaining the possibility of future recovery. Naloxone alone doesn't solve addiction, but it buys time, and time is what you need to find treatment, to build motivation for change, to access support. You can't recover if you're dead. Naloxone keeps people alive long enough to have a chance. Fentanyl test strips are small paper strips that detect the presence of fentanyl in drug samples.
A user can dissolve a tiny amount of their drugs in water, dip the strip, and within a minute see whether fentanyl is present. If the test is positive, they know to be more careful, use less, use with someone present, have naloxone ready. These strips are inexpensive, less than $1 each, and easy to use. Studies show that when people know their drugs contain fentanyl, they take precautions. They don't necessarily stop using, but they modify behavior in ways that reduce overdose risk. They use smaller amounts, they don't use alone, they prepare naloxone in advance. Fentanyl test strips save lives, yet in some jurisdictions they're classified as drug paraphernalia and are illegal to possess or distribute. The logic is Kafkaesque. The strips help people use drugs more safely, which arguably enables drug use, so they should be prohibited. This is like banning seatbelts because they make car crashes less deadly, thereby encouraging reckless driving. Harm reduction advocates have fought to change these laws with mixed success. Some states have legalized test strips, others maintain bans. The result is a patchwork where life-saving tools are available in some places but illegal in others for no coherent reason beyond moral objections to acknowledging that drug use exists. Supervised consumption sites, also called safe injection facilities, are spaces where people can use drugs under medical supervision. Staff don't provide drugs, but they provide clean equipment, observe for overdose, and provide immediate intervention if needed. They also connect users to social services, housing assistance, and addiction treatment when people are ready. Supervised consumption sites operate legally in Canada, Europe, and Australia. They've been studied extensively. The evidence is unambiguous. They reduce overdose deaths, reduce disease transmission,
Reduce public drug use, and increase treatment uptake. They don't increase drug use or crime in surrounding areas. They save lives and improve community health. Yet in the United States, supervised consumption sites remain largely illegal. Federal law prohibits operating facilities for the purpose of drug use, even medically supervised harm reduction. A handful of unsanctioned sites operate in a legal gray area, organizations that don't advertise what they're doing, but quietly provide supervised consumption services. They operate under constant threat of closure and prosecution. New York City opened the first officially sanctioned supervised consumption sites in the United States in 2021. Within the first year, they reversed over 300 overdoses with 0 deaths occurring on site. 300 people who would almost certainly have died instead survived. Yet political opposition remains fierce, with critics arguing that supervised sites enable addiction and send the wrong message. This is the fundamental tension in drug policy. Should the priority be preventing death and disease or preventing drug use? Harm reduction prioritizes the former. Prohibition prioritizes the latter. And when those priorities conflict, when keeping people alive requires acknowledging and accommodating drug use, prohibition sacrifices lives for symbolic purity. Needle exchange programs provide clean syringes to injection drug users, reducing transmission of HIV, hepatitis C, and bacterial infections. They've existed since the 1980s and have overwhelming evidence of effectiveness. Yet they remain controversial and underfunded, often operating on shoestring budgets from nonprofit organizations rather than government health departments. The logic of needle exchange is simple. People are going to inject drugs regardless of whether clean syringes are available. If they share or reuse syringes, they contract and spread diseases. Providing clean syringes doesn't increase drug use, but it dramatically reduces disease transmission. It's both humane and cost-effective. Preventing HIV and hepatitis infections saves far more in healthcare costs than providing needles costs. Yet needle exchanges face opposition from people who view them as enabling addiction. Some communities ban them, others tolerate but don't fund them. And so volunteers and activists run programs out of their own pockets, distributing needles from backpacks in parking lots, operating guerrilla harm reduction because official systems won't do it. The people running these harm reduction programs are often extraordinary. Many are current or former drug users themselves, people who've lost friends and loved ones to overdose, who've survived their own near deaths, who've seen the failures of the healthcare and criminal justice systems firsthand. They understand addiction not as an abstract concept, but as lived experience. They don't judge. They don't demand abstinence as a prerequisite for help. They meet people where they are, provide what's needed, and maintain relationships even through relapse and crisis. They save lives every day, often without recognition or funding, driven by the moral conviction that people who use drugs deserve to live. There's also peer recovery support, people in recovery mentoring others, providing hope that change is possible. Organizations like Narcotics Anonymous, Smart Recovery, and peer-run recovery centers provide community and structure for people trying to stay sober. Medication-assisted treatment, when accessible,
provides pharmacological support that dramatically improves recovery outcomes. Buprenorphine, sold as Suboxone, is a partial opioid agonist that prevents withdrawal and reduces craving without producing euphoria. Methadone is a full opioid agonist that works similarly. Both allow people to stabilize their lives, maintain employment, rebuild relationships, address underlying issues without the chaos of active addiction or the suffering of unmedicated withdrawal. Studies consistently show that medication-assisted treatment is more effective than abstinence-only approaches. People stay in treatment longer, have fewer relapses, and have better quality of life. Yet medication-assisted treatment remains stigmatized even within addiction treatment. Some programs refuse to admit people taking buprenorphine or methadone, arguing that it's just trading one addiction for another. This is medically illiterate and deadly. It's like refusing to treat diabetes with insulin because insulin dependence is just another addiction. The fight for survival in the fentanyl era is being waged by harm reduction activists, public health advocates, people in recovery, and grieving families who've turned their loss into action. They're fighting against stigma, underfunding, legal barriers, and institutional indifference. They're saving lives one naloxone kit, one fentanyl test strip, one clean needle at a time. They shouldn't have to. This should be government responsibility, funded
adequately and implemented systematically. But until that happens, grassroots harm reduction remains the difference between life and death for thousands of Americans every year. The fentanyl crisis is not static. It's evolving, driven by the same economic and chemical logic that created it. Understanding where this is headed requires looking at emerging threats, new synthetic opioids, and the trajectory of drug markets adapting to enforcement pressure. Fentanyl is not the endpoint. It's one molecule in a vast universe of possible synthetic opioids. Chemists can create thousands of opioid compounds, each with slightly different properties. Some of these have already appeared in the drug supply, others will emerge in the future, and some may be even more dangerous than fentanyl. Carfentanil, mentioned earlier, is one example, a fentanyl analog so potent that it's used for sedating elephants. It caused hundreds of deaths in 2016-2017 before largely disappearing from the drug supply, possibly because its lethality made it economically counterproductive. Dead customers don't generate repeat business. But other analogs have appeared: acetylfentanyl, furanylfentanyl, acryloyl fentanyl, cyclopropyl fentanyl. Each has slightly different potency and duration. Some are shorter acting, requiring more frequent dosing. Some produce more respiratory depression relative to euphoria, making them more dangerous. And because they're not specifically tested for in standard toxicology screens, overdose deaths may be misattributed to fentanyl when actually caused by analogs. The next generation of synthetic opioids may not even be fentanyl-based. Researchers have identified other chemical families, benzimidazoles, for example, that produce opioid effects through different mechanisms. These compounds, sometimes called new synthetic opioids or NSOs, are largely unknown to medical science. There's no research on their safety, no established dosing guidelines, no understanding of their toxicity profiles. If these substances enter the drug supply, they could produce overdose crises that naloxone can't reverse. Naloxone works by blocking mu-opioid receptors. If a new synthetic opioid acts through a different mechanism, naloxone might be ineffective. We'd be back to having no reversal agent, watching people die with no way to save them. There's also the issue of intentional design. The fentanyl analogs that emerged in the 1980s were designed to evade drug scheduling laws, technically legal because not yet specifically prohibited. Future synthetic opioids may be designed for other properties, easier to synthesize, harder to detect, more resistant to interdiction. The incentive structure of illegal drug markets rewards innovation that increases profitability and reduces risk for producers, not safety for users. Drug traffickers are also adapting to enforcement. As fentanyl interdiction increases, cartels are exploring new smuggling methods and routes. They're using drones to fly drugs across borders. They're concealing fentanyl in creative ways, dissolved in liquids, pressed into shapes that don't resemble drugs, chemically bonded to inert materials, and extracted later. They're also diversifying production. Instead of concentrating labs in a few regions of Mexico, they're establishing smaller, more distributed operations that are harder to find and shut down. Instead of relying on single supply chains for precursors, they're developing redundant sources and methods. This is a classic evolutionary process. Enforcement creates selection pressure.
Organizations and methods that survive enforcement pressure propagate. Less effective operations are eliminated. The result is a more sophisticated, resilient trafficking infrastructure that's harder to disrupt over time. Another concerning trend is the contamination of non-opioid drugs with fentanyl. As mentioned earlier, fentanyl is now appearing in cocaine, methamphetamine, and counterfeit prescription pills that aren't opioids. This is partly cross-contamination, dealers using the same equipment to process multiple drugs, and partly intentional, adding fentanyl to create physiological effects that customers might mistake for product quality. A cocaine user who snorts a line contaminated with fentanyl might interpret the sedation and warmth as really good coke, rather than recognizing it as opioid effects. They might seek out that dealer again, not realizing they're now using a fentanyl-laced product. This creates new populations of unintentional opioid users who develop dependence without understanding why. There's also the emerging threat of synthetic cannabinoids and other novel psychoactive substances being adulterated with fentanyl. The logic is the same. Fentanyl is cheap and potent, and adding small amounts can increase product strength. But users of these substances often have no opioid tolerance and no reason to suspect opioid contamination, making overdose deaths particularly likely.
The technological dimension is also evolving. Dark web marketplaces, encrypted messaging apps, and cryptocurrency have made drug transactions easier and more anonymous. People can order fentanyl from overseas vendors with relative ease, receiving shipments via mail. Law enforcement struggles to monitor these digital spaces, and even when they shut down one marketplace, others emerge. There's also the role of social media. Platforms like Snapchat, Instagram, and Facebook are used to advertise and sell drugs, including counterfeit pills containing fentanyl. Dealers use emojis and coded language to avoid detection. Young people who are native to these platforms can purchase drugs with the same ease they order food delivery. This accessibility expands the customer base and normalizes drug purchasing. The economic factors driving the crisis aren't changing either. As long as millions of Americans are addicted to opioids, there will be demand. As long as fentanyl is cheap to produce and highly profitable, there will be supply. As long as addiction treatment is difficult to access and economic opportunities are limited in many communities, people will continue using. Some experts predict the crisis will eventually plateau and decline, following the pattern of previous drug epidemics. The crack cocaine crisis peaked in the late 1980s, then declined through the 1990s as communities developed immunity, cultural knowledge about the drug's dangers, support systems for affected families, and reduced social acceptability. Perhaps the same will happen with fentanyl. Others are less optimistic. They point out that synthetic opioids are fundamentally different from plant-based drugs. There's no limit to production capacity. There's no seasonal variation or crop failures. The profit margins are so high that even aggressive enforcement only creates temporary disruptions. And the addiction is so powerful that demand remains constant regardless of consequences. The worst-case scenario is that fentanyl becomes a permanent feature of American society, an ongoing, low-intensity mass casualty event that we adopt to rather than solve. Overdose deaths might stabilize at current levels, 100,000 per year, and become accepted as background noise, like car accidents or flu deaths. Harm reduction becomes normalized not as a solution, but as a perpetual coping mechanism. There are also global concerns. The fentanyl crisis is currently concentrated in North America, but it's beginning to appear elsewhere. Fentanyl seizures are increasing in Europe, though deaths remain much lower. If the crisis globalizes, the death toll could reach hundreds of thousands annually worldwide. Preventing this requires interventions that don't yet exist at sufficient scale: universal access to addiction treatment, massive expansion of harm reduction services, economic investment in communities, reform of pain management practices, regulation of pharmaceutical marketing, and international cooperation on chemical precursor control. These are achievable goals. Other countries have managed opioid problems more effectively than the United States. Portugal decriminalized all drugs and invested in treatment, reducing overdose deaths by 80%. Switzerland implemented heroin-assisted treatment for severe addiction, allowing stabilization and reducing deaths. Canada expanded supervised consumption sites and naloxone access, saving thousands of lives. The solutions exist. The question is whether America has the political will to implement them. So far, the answer has been no. And so the fentanyl keeps flowing, the overdoses keep happening, and the death count keeps rising. What does it actually feel like to be caught in the fentanyl crisis right now, in 2024? Not the statistics, not the policy debates,
but the daily experience of addiction, survival, and attempted recovery in an environment where the drug supply is contaminated and help is hard to find. You wake up sick. That's the first reality. If you use fentanyl regularly, your body is dependent. Not using isn't an option. It's not about willpower or choice. It's about avoiding withdrawal, which is physically unbearable. Muscle aches, nausea, vomiting, diarrhea, anxiety, insomnia, cold sweats. Your body has adapted to expect opioids, and without them, it revolts. So you need to use. The question is how and when. If you have product left from yesterday, you use immediately. If not, you need to find money and find a dealer. This might mean panhandling, selling possessions, borrowing from people who will later resent you, or engaging in sex work, theft, or dealing yourself. Assume you find money, $40, enough for 1 or 2 doses. You contact your dealer, probably via text or Snapchat. You meet in a parking lot, a street corner, a fast food bathroom. The transaction takes 30 seconds. You get a tiny folded piece of paper with powder inside, or a blue pill, or a small rock of what's supposed to be heroin but is
Probably mostly fentanyl. You find somewhere to use. If you have a place to stay, you go there. If not, you find a bathroom, an alley, a hidden corner. Ideally, you'd use with someone present in case you overdose, but that requires having someone you trust who also has time and willingness to sit with you. Often you use alone. You prepare the dose. If it's powder, you dissolve it in water, draw it into a syringe, inject into a vein. If you still have accessible veins, many long-term users don't. Their veins collapsed and scarred from years of injections. They inject into muscle, which is less efficient and more painful, or they snort or smoke the drug instead. If it's a pill, you might swallow it, but more likely you crush and snort it or dissolve and inject it. Pills take longer to work when swallowed, and waiting is unbearable when you're sick. Within seconds to minutes, the drug hits. If you're lucky, it's relief. The withdrawal symptoms vanish. Warmth spreads through your body. The gnawing anxiety quiets. For a few hours, you feel okay. Not euphoric. Tolerance has eliminated euphoria, but okay, functional. You can think about something other than using. If you're unlucky, it's too much. The dose is stronger than expected, contaminated with more fentanyl than your body can handle. Your vision narrows. Your breathing slows. You lose consciousness. If someone finds you in time and administers naloxone, you wake up in withdrawal. The naloxone stripped opioids from your receptors, reversing the overdose but leaving you sick. If no one finds you, you die. Every use is Russian roulette. The powder looks the same every time, but the fentanyl content varies unpredictably. You might use the same amount you always use and be fine, or you might overdose. There's no way to know. Assuming you survive the morning dose, you have a few hours of functionality. Maybe you try to work. Some people maintain employment even while addicted, though it's difficult. Maybe you handle errands, see family, pretend everything is normal. Maybe you just exist, scrolling your phone, watching TV, doing nothing, because doing nothing is still better than withdrawal. By afternoon, you're starting to feel sick again. Fentanyl has a short duration, 4 to 6 hours at most, often less. You need to use again. That means finding more money, contacting the dealer again, going through the whole process. Most fentanyl users need to use 3 to 5 times per day to avoid withdrawal. It's exhausting, expensive, and all-consuming. Some people try to taper, to reduce their doses gradually and get off fentanyl. It rarely works. The withdrawal is too intense, and the drug supply is too inconsistent to control dosing precisely. Others try to switch to buprenorphine, which blocks withdrawal and allows stabilization. But accessing buprenorphine requires finding a doctor authorized to prescribe it, making appointments, having insurance or money for treatment. Many people can't navigate those barriers while actively addicted. Some try to stop cold turkey. They endure withdrawal, 3 to 5 days of acute misery, followed by weeks of depression, insomnia, and cravings. A tiny percentage succeed. Most relapse, often overdosing because their tolerance has decreased during abstinence. Structured treatment, detox facilities, residential rehab, outpatient programs works better, but most people can't access it. Treatment beds are scarce, waiting lists are long, costs are prohibitive, insurance coverage is limited. And even when people do get into treatment, completion rates are low. Addiction is a chronic condition, and relapse is common. One treatment episode is rarely enough. Living with fentanyl addiction means living in constant danger. Every use might be the last. Friends die regularly. You go to funerals, memorials, vigils. You see the grief of families, the horror on parents' faces. You think that won't be me, but you know it might be. You've probably overdosed before, been revived with naloxone, woken up surrounded by paramedics.
It didn't stop you, because addiction isn't a choice you can just unchoose. There's also the stigma. Society views addiction as a moral failing. Family members are ashamed, angry, exhausted. Strangers judge, employers discriminate. Healthcare providers treat you dismissively, assuming you're drug-seeking. Police view you as criminal. You internalize this stigma, believing you're worthless, that you deserve suffering, that recovery isn't possible for someone like you. And yet, people do recover. Not everyone, not easily, but it happens. Sometimes through treatment, sometimes through sheer determination, sometimes because circumstances change, a relationship, a job opportunity, a near-death experience that finally breaks through the addiction. Recovery usually requires multiple attempts. You try and fail and try again. You might get clean for a week, a month, a year, then relapse. That doesn't mean you failed. It means addiction is
powerful and recovery is hard, but each attempt teaches you something. Each period of sobriety, it demonstrates that a different life is possible. Support systems matter enormously. People with family support, stable housing, and access to treatment have better outcomes. People who are homeless, isolated, and locked out of services have worse outcomes. This isn't about willpower or moral character. It's about resources and opportunity. Medication-assisted treatment is often key. Buprenorphine or methadone allows people to stabilize, to stop the daily chase for drugs, to address the underlying issues that contributed to addiction. It's not a cure, but it's management, and management is often sufficient to rebuild a life. Peer support is also critical. Being around people who understand addiction from lived experience, who don't judge, who can offer hope and practical advice makes an enormous difference. Recovery communities provide structure, accountability, and connection, things addiction destroys and recovery requires. Some people achieve sustained recovery and rebuild their lives completely. They get jobs, repair relationships, become advocates helping others. They're living proof that recovery is possible even from severe fentanyl addiction. But they're also quick to acknowledge how much luck was involved. The right treatment at the right time, the support they received, the fact that they survived when others didn't. Living with fentanyl in 2024 means living in a state of emergency that has become normalized. Overdoses are common, deaths are frequent. Harm reduction is necessary but insufficient. Treatment is available but inadequate. And every day you make the choice to keep trying to survive, to keep seeking recovery, or to give up. Most people choose to keep trying because despite everything, the stigma, the suffering, the near constant danger, humans are resilient. We want to live. We want to recover. We want things to be better. And as long as that want exists, there's hope. It's 2024 now. Fentanyl has been the leading cause of death for Americans aged 18 to 45 for 5 years. Over 700,000 Americans have died from drug overdoses since the crisis began, the majority involving synthetic opioids. That's more than died in all American wars combined. It's a death toll comparable to the Civil War, unfolding not over 4 years, but over 2 decades, and it's still accelerating. This is not a natural disaster. It's not an unavoidable tragedy. It's the result of specific decisions, policy failures, and systemic problems that could be addressed if we chose to prioritize them. We know what works. Harm reduction saves lives. Medication-assisted treatment works. Supervised consumption sites prevent deaths. Addressing pain through comprehensive care instead of pills prevents addiction. Decriminalizing drug use and investing in treatment reduces harm. These aren't theories, they're evidence-based interventions proven effective in other countries and in American pilot programs. We also know what doesn't work. Criminalization doesn't reduce drug use, it just makes it more dangerous. Border walls don't stop fentanyl, the flow continues regardless. Just say no messaging doesn't prevent addiction, it just increases stigma. Cutting off prescription opioids without providing alternatives doesn't solve addiction, it just drives people to street drugs. Yet American drug policy continues to prioritize approaches that don't work over approaches that do. We spend billions on interdiction and incarceration, pennies on treatment and harm reduction. We arrest people dying of a disease and call it justice. We watch 100,000 people die every year and debate whether providing them with clean syringes sends the wrong message. The elephant in the room, and the title of this video references elephants for a reason since carfentanil was designed for elephant sedation, is that we could stop this.
Not completely, not immediately, but substantially. We could save tens of thousands of lives per year if we chose to. We could make naloxone available everywhere, free and without stigma. We could expand medication-assisted treatment until everyone who needs it can access it. We could open supervised consumption sites in every city. We could decriminalize drug use and redirect resources from punishment to treatment. We could regulate pain management in ways that balance legitimate suffering with addiction risk. We could pressure China and Mexico more effectively on precursor chemicals. We could fund research into addiction treatment and overdose reversal. All of this is possible. The barrier isn't knowledge or capability, it's will. It's the political will to treat addiction as a health issue rather than a crime. It's the social will to extend compassion to people who use drugs. It's the moral will to prioritize saving lives over enforcing morality. Until that changes, the fentanyl crisis will continue. People will keep using because addiction is
compulsive and pain is real. Fentanyl will keep flowing because it's profitable and demand is insatiable. People will keep dying, 150 every day, and we'll keep calling it a tragedy while doing far less than we could to prevent it. The history of fentanyl is a history of human ingenuity turned deadly. A Belgian chemist created a molecule to reduce surgical pain. Chinese manufacturers scaled production to global proportions. Mexican cartels weaponized it for profit. American drug policy failed to respond adequately. And now, millions of people live in the shadow of a substance so potent that an amount smaller than a grain of salt can end a life. Why wouldn't you survive the fentanyl era? Because the systems meant to protect you, healthcare, drug enforcement, social services, are broken. Because the drug supply is contaminated in ways you can't detect. Because addiction is a disease that hijacks your brain's reward system, making rational choice nearly impossible. Because help is hard to find and easy to lose. Because one mistake, one contaminated pill, one hot spot in a batch can kill you instantly. Some people survive through luck, through access to treatment, through strength and support and timing. But survival shouldn't require luck. It should be the default. And it could be if we built systems designed to preserve life instead of punishing people for being sick. If you've made it through this entire video, thank you for listening. If you or someone you love is struggling with addiction, please know that recovery is possible and help, though insufficient, does exist. The Substance Abuse and Mental Health Services Administration has a national helpline, 1-800-662-4357. It's free, confidential, and available 24/7. If you found this video valuable, consider liking it and subscribing. Share it with people who need to understand this crisis. The more we understand about fentanyl, its history, its dangers, the failures that enabled it, the better equipped we are to respond with compassion and effectiveness instead of stigma and punishment. Thank you for your time. Take care of yourself and the people around you. Sleep well and wake up tomorrow ready to build a world that values survival over judgment.